closest to the image receptor.
Yes.
Oh, okay, that was my issue.
All right, well, I can't do it. Just, you'll have to take my word for it.
Is it just cost?
No,
I mean, not
15
this.
degrees.
I think I have the cheaper version.
Yeah. Yeah. Because when you tilt it on the, when you like this, okay, so you're doing 15, 15. This cheekbone now is superimposed with the skull. This one kind of frees it just slightly.
No, it's not superimposed.
Here, I think she needs it more than I do.
Yes, I'm taking it
She's
home.
going to take a look at it. Okay.
It's
All right, so
superimposed.
got that 15, 15. 15 rotation, 15 tilt. And then you skim the ramus, and now you have it isolated. Okay. Again, lower kV, we don't care about all these other structures. We want to use a low kV just to isolate the zygomatic. So again, if we're doing the oblique infrasuperior, this is for unilateral, just one. Okay? Okay, we are still with the
Bless you.
cheekbone. So here's the AP axial. What do we know this as?
Towns.
This is the towns. So this is also the towns. So depending on if we're using the OML or the IOML, okay, so central ray is going to be superior, 1 inch superior to the glabella to pass through the mid arches. Okay, you guys already know this with the skull. The only thing that's going to change is the central ray. So central ray is going to be 1 inch above the glabella. Okay, and it looks like that. It looks distorted, it looks elongated, it looks like an alien. Everything looks washed out because, again, we're using low exposure factors to visualize just the cheekbones, the zygomatic bones. Okay? That's it. Next is mandible. Same views. Here we go. Axiolateral mandible. Axiolateral mandible. So what's going to happen here is from a true lateral position, patient is going to tilt their head approximately 25 degrees. So this and this is 25 degrees. Okay, from a true lateral. Now, if the patient cannot tilt their head and they're like this, what can I do now?
Angle the tube.
Tilt their body?
Angle the tube somehow.
I like that, huh? So we're going to angle 25 degrees. So if they can't tilt their head and straight up and down, we're going to angle 25 degrees. Whatever it is, if I can tilt my head 5 degrees, what should my central ray be? 20 degrees. If I can tilt it 10 degrees, this is going to be what?
15.
15 degrees. So you guys are answering my question in that whatever the tilt is, whatever they can accomplish, the relationship between your central ray and the tilt, using your interpupillary lines, whatever the tilt is, it has to equal 25 degrees. Okay? So whatever the combination is of the head tilt and the central ray, it has to equal 25.
Where's the point you're using to determine how much they're tilting their head?
The interpupillary line.
No, I mean just for like how much they're able to. Okay.
Between here and here?
Yeah.
Yeah, this is 25 degrees. Okay. Now, this is where it gets a little bit confused, if it's not confusing already. This is where it gets confused. So, again, 25 degrees tilt or whatever combination between your central ray and your interpupillaries, it has to match 25 degrees, okay? Now, we can add a rotation to the mandible depending on what we're looking at. So this one, for instance, after they tilted their head 25 degrees with a 0 degree central ray, they rotated it approximately 30 degrees. And the reason for that is we're going to look at the body of the mandible. So here we have the ramus, here we have the body. So this is the ramus, this is the body. So we're looking at the body of the mandible. Okay, so here's some other pictures again. Here's 25, here's 25. It all has to be 25, okay? Here's one where it is traumatic. Again, they have a 25-degree angulation. They're just throwing this in the mix because what would happen if it was traumatic? You're trying to get the 25, but your central ray is hitting the shoulder. Okay? So what they're saying here is we're going to raise the tube up a little bit so we're not on the shoulder, and then we're going to angle downwards posteriorly so the shoulder is not in view. Okay? Now, if we hit on over here, let's look at this. The general rotation, so again, is if we're just doing just a regular axial lateral, it's just going to be 25 degrees. If I wanted to do a general survey, it's going to be 15 degrees. If I want to look at body, it's going to be 30 degrees. If I wanted to look at momentum, it's going to be 45 degrees. I'm going to use my app to show you guys how this works, okay? This will make more sense because I was playing with this earlier and it was so cool. Okay, let's pull this baby up. Okay, you guys watching? Okay, so we said that we are going to do, so it's going to be, first of all, we start off with a 25-degree tilt, right? So there's our 25-degree tilt. Okay? This is just your basic. If we want to do a general survey, you guys refer to your slides there. If we want to do a general survey, it's going to be a 10 to 15-degree rotation. Okay, that's just a general survey. We remove superimposition. If I wanted to look at the body, this part right here is going to be a 30-degree rotation. So now we can see the body. If I wanted to look at this area now it's going to be 45 degrees. And now I can see the mentum. Okay? So here's your tilt, 15 degree for general survey, 30 degree for the body, 45 degrees to look at the mentum. Okay. So general survey. If I want to look at the body, 30 degrees. If I want to look at the mentum, 45 degrees. And then just a true lateral to look at the ramus. This area right here. Makes a lot more sense when I do the 3D app, huh? Yeah, it does. Okay. All right. So here, what do we have here? Which one is this? 30 degree? We're looking at this, huh? This is 30 degrees right here. So we're looking at the body. So the other part of the mandible is this. Here's the other mandible. Other half is going up this way. All right. PA mandible. PA mandible. So patient is face down. We're going to do instead of 15 degrees, we're going to do 25 degrees. 15 was for the Caldwell, right? So we're going to give it an extra 10 degrees here for the PA mandible. using the OML perpendicular to the image receptor exiting the lips. Again, Gio, we said this earlier, well, how do I know where to center? Well, don't look at centering here, look at where the crosshairs are as it's exiting, and put that at the level of the lips. Okay. So optional PA axial central ray is 20 to 25 to better visualize the condyles if preferred. Okay. 2025. But that's the option. Generally, it's just the PA with a 0 degrees. If you want to use the angle, instead of 15 for condyle, we can do a 25 for better visualization of the heads. Okay, with the entire mandible demonstrated. AP axial. Again, what is this? This is simply the talons, but for the mandible. So OML, perpendicular, 35 to 40 degree caudal angle, but now we're looking up a little bit higher. We're not looking at the cheekbones anymore. So we're gonna, instead of the nasal, now we're gonna go at the glabella because we're a little bit higher here. So we're gonna look at the articulation with the temporal bone. And so this is really good for looking at the condyloid process right here. So it's AP axial, centered at the glabella, good for looking at the condyloid process and its articulation with the temporal bone. SMV, okay, same thing. It was same thing as this was the same thing as the cheekbones, zygoma, top of the head, flush with the image receptor, and we're going to center 1.5 inches below the mandibular symphysis. That was the same thing as the cheekbones, wasn't it? Okay, same thing. Same thing as the cheekbones. Okay, except here's the difference. Remember when we did the SMV for the cheekbones, for the zygomas, this was all white. You couldn't see it, and all you saw were the jug handles. So here we're going to increase our technical factor so we can see the mandible. So that was the only difference between the two. With the zygoma, it was a lighter technique. For the mandible, it's a higher technique. But central ray positioning is all the same. Okay. Panorex. Any of you guys have Panorex at your facility?
Yeah.
Okay. Has anybody had a Panorex done before for dental work?
Yeah.
Okay. So here it's a one single image, and as they're making an exposure, the exposure can be anywhere between 3, 4, 5, 6 seconds as the X-ray tube is making its way around your face. The cassette is very unique. It's a curved cassette. And again, it makes an exposure as around your face. And the proper positioning for a Panorex, again, some of you guys have these at your facilities and you may be using this. So they got this head holder that keeps your head in place, preventing you from moving. It also allows you for good positioning. And the key here is putting your IOML parallel to the floor. So here's an example where we don't want them extending their neck. They should be completely straight up and down without any leaning forward, okay? And placing your IOML parallel with the floor for a proper position for a Panorex. And so you should have an exposure for the entire mouth. So there's some movement because, again, it looks like there's some blurring because there is blurring because the X-ray tube is actually moving as it's taking an X-ray. Okay. TMJs. What are TMJs? Okay, temporomandibular joint. So here we have, again, we have the AP axial. There's your talons. Okay, there's your talons again. Because we're moving higher now, instead of 1/2 inch, 1.5 above the glabella, we're going to be about 2 inches above the glabella. Everything is the same. positioning the same, we're just centering up a little higher. It says here that you can take comparison views in this projection, one with a closed mouth, one with an open mouth, because remember what happens to your TMJs as you open them. They're going to move forward, right? So we want to do a comparison. All right, so here is the TMJ. There's the condyloid. Here is the fossa, and here's the space right here. That's your TMJ. And there's your space right there too, the TMJ of the other side. And here I attach a quick reference of all the axials. So if we're looking at occipital, because it's the highest, 2.5 above the glabella, we're moving our way down, TMJ. So we're now 2 inches above the glabella, moving lower, 1 inch above the glabella, okay? And then the mandible at the glabella. Okay? They're all the same positions. Here is an axiolateral oblique. This is to, again, to assess the TMJs. So from a true lateral position, we're going to rotate the face approximately 15 degrees towards the image receptor from a true lateral with a 15-degree angle towards the feet. So this law method is what they call it. It's the 15-15. 15 rotation, 15-degree caudal angle to the affected side. Central ray is going to be 1.5 inches superior to the upside EAM. So it's going to be 1.5 inches above the EAM. But which TMJ are we looking at here? So we're actually, so a central ray is up here, but we're actually looking at the TMJ, the downside TMJ. Yes. Okay. And again, we do it open mouth and we do it closed mouth for comparison. Open and closed. 15 and 15, open and closed. Okay, so there's the closed. So the condyloid, the head should be inside the fossa of the temporal bone. And we don't need a large field, just calling it to the area of interest. Okay, open and closed, open and closed. Here is one with, you guys remember tomograms? We talked about it a couple of weeks ago. So tomograms can also be conducted with TMJs. Look at the relationship between the condylar head and here's the fossa right here. Normal position is this should be over here anterior to it, but it's on the back side. Poor guy. Schuler's method, true lateral. There's nothing fancy about this. It's just a 25 to 30 degree angulation towards the feet. That's it. True lateral with a 20 to 30 degree angulation. Center 1.5 inches anterior and 2 inches superior to the upside AAM again, but we're looking at the downside TMJ. This is Schuler method. Okay, again, open and mouth, open and mouth, open and close. Can you guys see the pinna of the ear?
And what's that? Oh.
Is it pinna? It's called pinna, right? Yeah. Pinna of the ear. And you have your EAM right here. The external auditory meatus, TMJ. In a normal movement, when you open up your mouth, again, it moves anteriorly. It should move forward. That's normal. And there's that tomogram. And I'm not going to spend too much time on that. You guys can look on this on your own. Okay. Paranasal sinus routine. Okay. Same views as what? Same views as the skull. The only difference here is we're looking at sinuses. So if we're looking at sinuses, we're looking at air-filled sinuses. What do you think our technical factors are going to be?
Low.
They're going to be low, right? These are all the exact same positions. So here is the OML perpendicular. Okay, oh, I'm sorry, technical considerations. I jumped ahead. Okay, so you want to do it upright because we want to look at air fluid levels. We recommend you not using an AEC because when you use an AEC, your exposure is going to be based on the thickness or the density of your head. So it's going to make a normal exposure based on your skull, okay, not your sinuses. And that's why we recommend not using an AEC, using light technical factors. Okay, and again, suspend. If you just say hold still, don't move. Hold still, don't move. It says no respiration.
Mr. Bean.
I'm just making sure you guys are awake. See, I didn't hear any laughing. I heard you guys are falling asleep back there. Who's this?
Mr. Bean.
Mr. Bean. All right, here's the lateral sinus.
Aww.
Oh, you like that other one better?
He's so sad.
All right, lateral sinus. True lateral, mid-sagittal plane, parallel, interpupillary, perpendicular. Central ray is going to be between the outer campus and the EAM. That was the same thing as the lateral facial bones, right? Except we're going to use a light technique, okay? All right, I'm going to keep on moving. P.A. Caldwell, OML, perpendicular, 15-degree angulation towards the feet. Central ray is going to exit the nasion. This is interesting over here because here we have a perpendicular image receptor, but we angled our perpendicular central ray, but we angled the image receptor 15 degrees. I think both our rooms do that, right?
Yeah.
Okay. So you can practice doing that too if you want.
So it's like if we love the image receptor, let's say straight, then we'll have to angle the beam?
Yeah, so it's one or the other. One or the other. Okay. So this is good for evaluating, again, here's a question. Okay, lateral. If I were to ask you which position is good for evaluating all the sinuses, what are you going to tell me? Oh, right here. It says right here, all four sinuses are demonstrated. So this is the projection, the view that demonstrates all the sinuses. All the sinuses. Okay, so highlight that. Now here we have the P.A. Caldwell, so which sinus are we looking at here?
Frontal.
This is good for the frontal sinus. As it was good for evaluating the frontal bone, this is also good for the frontal sinuses. You will see the ethmoid and sphenoid sinuses, but they're superimposed. You won't see the maxillaries because look at where the petrous portion is. So this is good for the frontal sinus. Here is the Waters view. Mental meatal line. Perpendicular to the image receptor. So what are we doing here? What do you think is going to happen to those petrous ridges? Where are they going to go? They're going to go low, right? They're going to go down. So then this would be good. Would be good for what?
Orbit.
Be good for the maxillary sinuses. Because the petrous ridges, the portion is way down here now. So this is a good evaluation for the maxillary sinus. You're going to get some distortion over here in the frontal, but good for maxillaries. Because the petrous ridges, the petrous portion is going to be driven below the maxillary sinuses. And the sphenoid is in there, but you can't see it because it's behind the teeth. So how are we going to see that sphenoid sinus in this particular position? What are we going to have the patient do? We're going to have them open up their mouth. Okay, that's going to be in the next view coming up. Here is an SMV. Okay, SMV. So we see the maxillaries barely, but again, here we see the Mickey Mouse. There's your ethmoid, and then right behind that is going to be your sphenoid. Okay. Am I going too fast?
No.
All right, here is the PA transoral waters. We just call it the open mouth waters. But that is the formal name, is the PA transoral waters or the open mouth waters. All right. So the mental meatal line is going to be perpendicular. Does it look like it's perpendicular there? Here's the catch. You position them like this first, so mental meatal. Okay? All right, you guys follow?
Yeah.
Now have them open up their mouth.
Oh, okay.
See it? If you open up your mouth and then position them, now you're going to be totally off. So you position them in their A and then ML. This in a closed mouth position first, and then have them open it. Okay? Exit the acampion. Open mouth. So in the open mouth, we should see now the sphenoid sinus. Okay. I think we're done. We're just looking at some images now. Okay. Which one do you like? A or B?
Facial bones?
Why isn't A good? Yeah, this is for facial bones. Why isn't A good?
Slowness rotation.
There's some, okay, you guys hear that? Here is one going in, here's another going in.
Also the nasal.
So there is some rotation, right?
But Salatursica is only
That's the more
one.
rigid the
Okay, so this is more of a, this is a tilt or rotation issue.
Rotation.
This is a rotation issue. So there is no tilt, it's a rotation issue. Because I'm seeing one posterior border of the orbit and I see another one here too. These should be superimposed. Like they are over here, they're superimposed, you only see one, right?
Yeah.
And they will also have one mandible. But also what's going on here? If this is a facial bone, are we cutting something off? Cutting off the chin. Okay, so we got that. All right. Which demonstrates one or more repeatable errors in radiograph A or B? What do you like better, A or B?
B.
We like B. Okay, why do we like B?
A is rotated. No,
Okay, so A, there was some rotation.
it's not clear.
also washed out.
It's okay, so it's kind of grayish. It should be more black and white. So it looks like they use higher KVs than they did over here. What else?
Tilt?
Yeah, I think they should extend their chin a little bit more because it looks like it's going over the lower part of the maxillary sinuses, so it's not really free and clear. So they need to extend their head a little bit more on this one. You guys agree? Okay. SMV. The mentum, and a good SMV, the mentum, the bottom of the jaw, should be superimposed over the frontal bone. Does it look like it's superimposed on the frontal bone over here? Are you seeing the frontal bone over here? No. Are you seeing it over here? Yeah, it's way up here. Okay. So this is an improperly positioned SMV. Okay. Where's that located? If I cut this into fours. Okay. It's not really in the quadrant. It's kind of in between two quadrants, right? Now,
So it's under rotated.
it is. It's under rotated. It's under rotated, yeah. So they didn't get that 37 degrees. But look, would that be acceptable?
Because you can still see.
Yes, you can see it. This is just being anal now if you don't accept that. It should be over here, but that's still a good view of the optic foramen, and I can see the strut. But that is better because it's on the lower outer.
Mm-hmm.
This is in between, but this is still acceptable. And this one you don't even know where it is. It's not there. I can't even tell you if it's over or under. But you can't see it there, right? These are good? You can't see it here. I know you guys are tired. Bear with me. Okay. What's wrong? See, if you know x-rays, this is funny. What's wrong with this? Okay, this is supposed to be an open mouth waters, okay? Where are the Petrus ridges? They are way down. They're here in the maxillary sinuses, so they should be below. All right? So what should have been done here to make sure that these are lower? So greater head extension, right? Okay. Are you guys okay with this? Rotated, tilted, okay. It's just messed up, okay. That's a medical phrase, it's messed up. How about this? Do we have full extension? Does the vertex look like it's on the top of the image receptor? No. All right, you guys got it. All right. All right, guys, we'll be back here at 4 o'clock. Go on a lunch break, we'll see you at 4. Yeah, same thing. So, yeah.
On your syllabus, it says the quiz next week is on facial bones, nasal, and orbits.
They're all part of the facial bones.
But okay, so we're all
Yeah, it's all inclusive. Whatever we covered today.